Wow, thank you for packing our space, room number 11. It's a little bit bigger from last year. Thank you, ITEP. I am so excited to be here for this panel, and I hope you feel it too, because this group right here is extra, extra special. And I also just want to say how amazing it is to be in person, because we've been doing a lot of work remotely. And again, it's really, really special. So let's get into our panel today. I'm joined by the esteemed Rhonda Smith, who is the Executive Director of the California Black Health Network, where she is tirelessly championing better health for Black Californians and in turn, all of us. Also, Dr. Paula Barberia, right there, California Department of Healthcare Services, and the Chief Quality Officer and Deputy Director of Quality and Population Health Management.
It's a long time.
And again, tirelessly working for all of us with the anxiously awaited population health management tool that we'll learn more about today. And also Dr. Manisha Sharma, who is the Blue Shield of California Promise Health Plan, the Medicaid plan in California, or Medi-Cal plan in California, and she is their Chief Medical Officer.
Senior Medical Director.
Senior Medical Officer. See, I didn't look at my notes.
That's okay.
And also I had the pleasure of joining Manisha on our consent management webinar. If you haven't seen it, please take a look. Who brought the conversation, which I know she'll do today, into the most genuine and humanitarian conversation that I've ever had the pleasure of being able to facilitate. So go check it out because it's really incredible.
Thank you.
And thank you.
Thank you.
So to get us started today, our topic is around how do we think about making sure that as we are exchanging all this data, applying it in the right way, that it is unbiased in nature. And I think it's just been kind of sparked this conversation over the last few years with some publications that have really been eye-opening about how we think that we're applying this big data and this AI and these data algorithms to be able to better serving the right people at the right time with the right information. But in fact, it's actually done just the opposite. And what we're going to hear on this panel today, which is just also so exciting for me personally and our team as we prepared for today, is what these women are doing every day in a practical way. I'm floored because they're getting ahead of it and de-risking the system, which thank goodness we have this leadership here to do just that, and that's what we're going to learn about. So I'm just going to get us started, which I think is my job today. Just watch, and we'll talk about it at the end. All I have to do is get them started, and we're in for a ride. So I'm going to turn to you first, Rhonda, who also introducing myself real quick. I am the Executive Director of Blue Path Health. We're a consulting firm in California to advance strategy and policy and implementation, but I am also the Executive Director of Connecting for Better Health, and Rhonda's on my board, which is pretty also amazing. We just stood it up at the end of last year. And Connecting for Better Health, for all of you, is to come into the tent and advance data sharing in California. Happy to connect with you after this panel. But Rhonda, just to get it started, I'm gonna go to each of you. Can you tell us a little bit about what you do on a day-to-day basis and how you think about data sharing and making sure that the bias that inherently has existed in the system is not there going forward?
Yeah, so aside from spending all day on Zoom calls, what we do every day is really focused on trying to close the gap in health disparities for all Black Californians. And we do that in a number of ways. We do a lot of outreach, we do education to really empower our community to take control of their own health and well-being and be at the center of that. We get involved in policy work and advocacy work, and a lot of our policy work is really focusing more on trying to get to the root causes of health disparities and health inequities to begin with, and breaking down those barriers and structural and systemic reasons for poor health outcomes for our community. We also are a Covered California Navigator, so health equity begins with access to health care. So we have a network of certified enrollment counselors across the state who work to enroll those that are uninsured and make sure those who do have insurance stay enrolled. Yeah, and so we work tirelessly every day trying to do this across the state for our community. And I think starting with the idea of data sharing and what goes into an EHR system. And so I'd like to start with like making sure that we address the issue with SOAP notes, right, being more subjective than objective, and maybe even not much of a plan, but we know that oftentimes providers make assumptions about patients, irregardless of what's really happening in that patient's life. I mean, health really happens outside the four walls of any healthcare center. So as we know, 80% of what contributes to health outcomes is related to social determinants of health and 20% only clinical. So if we're able to, or if providers were able to really be more objective and do more motivational interviewing or really understanding what is happening with a patient or the reason why a particular patient may not have been compliant with their medication, instead of assuming and labeling and misrepresenting the reasons why, I think starting there in terms of what goes into an EHR system might be the source, and eliminating some of the racial bias that is embedded or part of that process. And for us, one of the things that, well, we're doing a number of things. One of the things that we're also working on is we're part of a coalition that is looking at how we can replicate and model what a group in New York has done to really address the racial bias that's embedded into medical algorithms. So the group in New York is called the Coalition to End Racial Bias in Algorithms, or CIRCA for short. And so we've been working as a collective over the last few months, really trying to figure out how we could apply that here in California and what potential policy solutions or initiatives we might be able to engage in. And we know that it's important to really eliminate race-based medicine practices. We're all human beings. And so doing race-based adjusted decision-making for patient care should not happen within our medical system, and we know what role that plays in the differences in outcomes between patients purely based on race, given the same circumstances and conditions. And so hopefully, a year from now, we'll have much more information to share about our success and progress that we've made on that front, especially from a policy standpoint. One of the other things that we're working on, and we're fortunate to collaborate and partner with the California Healthcare Foundation on some of the implementation of their recommendations from the Listening to Black Californians research report. And tomorrow night, actually, we're having a launch event here in Sacramento to really, I say, we're igniting a Black health movement here in California. And through the How Do I campaign, which is one of the recommendations that came out of that research, we're engaging community. So we're not only going to have broader education and engagement, but really going to our communities to meet people where they are. I say where people shop, play, pray, and slay. And so we'll be having a series of community-based conversations. We're going to hair salons and barbershops and churches and Black-owned businesses, coffee shops, so we want to make sure that we're reaching the community and we're going where people are and are in safe and trusted spaces to have these conversations, because I truly believe that we have to be empowered to take charge of our own health and well-being. And the work that we'll be doing will really focus on helping patients understand and individuals understand what their patient rights are, how to have a conversation with their healthcare provider, no matter who or what type of provider they're dealing with, how to navigate through the healthcare system, how to advocate for themselves and their loved ones, how to really participate in the decision-making for their care, and be at the center of that and really own the power in that dynamic between their healthcare provider and themselves. And I believe that, as much as I'd like to think we've made progress, we still have a ways to go. And no matter how much we spend on doing work in health disparities or how much we bang our heads against the wall, our infrastructure for this country was built on racism, and that's not going away anytime soon. So I think if we are able to empower our community to really take ownership and really take charge of their health and well-being, then maybe we can shrink that big R to a little r, and it won't matter what that individual encounters when they're interacting with the healthcare system or faced with discrimination or racial bias. They will know how to respond appropriately and really take power in that situation and work to their advantage. So So that's part of what we're doing.
We'll come back.
That's
We
a
will
part of what
come
we're
back.
doing.
You know, I love learning about the New York effort, but there's a little bit of competitiveness in me too, for those of you that know me, and why New York is ahead of us there and why aren't we? But we'll come back to that because we'll take what they're doing and
I've only
leapfrog.
been around for a couple of
I
years.
know, I know.
Sorry, yeah, sorry.
Paula, let's turn to you, and especially this. There's a lot of connections here.
Yeah, so much to pick up on. So a few things that I'll call out. You know, obviously, I'm from DHCS, so we administer Medi-Cal and CalAIM, and all of you in this room are probably touching the work that we are doing in some way, shape, or form and making this incredible transformation of Medi-Cal in our state possible. And so first and foremost, I'm so grateful to all of you for being on this journey. We know it's bumpy at times, and we're trying to address some of those issues. I think when my team obviously oversees everything related to quality, health equity, population health, ECM, and then the population health management service. But some of the grounding principles in our comprehensive quality strategy, which we published in 2022 and submitted to CMS, it's rooted in guiding principles of transparency, accountability, and member-centeredness to really achieve health equity and eliminate disparities. And so I always come back to those as the overarching principles. And I think rooting our data conversation in that I find to be a really helpful rubric. So in terms of transparency, we know that so many of the disparities are worse when they are hidden and people can't interrogate them, right? If you can bring the disparities to light, if you can bring the flawed, racially biased algorithms to light, then we can have a conversation about how do we fix this in a data-driven way. And that is something that we take really seriously. So a few things that we are doing at DHCS. One, you all have hopefully seen a lot more data coming out of the department. If you missed it, we published the CalAIM dashboard last Friday. It is a publicly accessible website. It is a treasure trove of data that we will continue to update to get really granular. And like our bold goals page there, we are stratifying different quality measures by race and ethnicity and looking at targets. We will get even more granular to be able to look at things at the county level, look at it by primary language, look at it by plan level. We similarly in December published the long-term supports and services dashboard, totally publicly available. Recognize not everything is, not every quality measure that we would want to report on or every slice and dice we would want to do is there, but it is literally a data dump of all of the data we have in a user digestible way. So not the open data portal where you need a stats degree to interpret the Excel file. I mean, some of you can do that in this room. I can't. And so I really appreciate the interactive dashboards where you can look and be like, we have disparities. There are counties and plans that are sort of leaving populations behind because they don't speak English, they don't come from a certain race or ethnicity, and the more we can create sort of public awareness and mutual accountability, that is a major tool in our toolbox to really close these disparities. I think the other way in which transparency manifests is, in addition to my day job, I still see patients a half day a week. And as many of you know, really picking up on Rhonda's comments about what is written in medical records and what sorts of, both conscious and unconscious biases are brought into medical practice. Over the last, multiple years, there's been a huge push to democratize that data and make what is written in someone's medical chart really easily accessible to the patient. And that has opened up a flood of conversations. So in my half-day a week of clinical practice, I also supervise residents, and we have that conversation. If you write about this patient using this word or that word, maybe it's technically accurate, but they're going to read this, and what is that going to do to their trust in the system, their relationship with you, and that person seeking you out when they need help? And that sort of conversation really has enabled us, I think, to move to a much better place where that medical record isn't just a biased assumption of a provider about a patient, but really a shared decision-making tool and a documentation tool where both of them can really care plan and take care of that patient, right? And so I think just increased transparency in any way in which we can get there on all sides really helps us, I think, to address some of these underlying issues. Accountability is obviously a big part of this too, and I think as we think about our population health management service, which is coming, I promise, we will sometime this year definitely release a public timeline so you all will know when it's coming, but there's a lot of furious behind the scenes planning that is happening right now. And you all can imagine, for those of you who haven't been tracking, the Pop Health Service is really a population health management data analytics platform that is designed to make data about Medi-Cal members available to our plans, to our providers. There's going to be a member portal-facing component, and for DHCS to use as well. And it's really, not a replacement for the amazing data exchange framework that's been happening around the state. We hope to leverage some of that healthcare data from the data exchange framework, but we're also looking at how do we bring in non-healthcare data sources to really achieve whole person care. So things like public health data, correctional data for our Justice Involved initiative. You probably heard a lot about that this morning. Thinking about WIC and CalFresh enrollment data. We know there's huge opportunities where Medi-Cal members aren't taking advantage of benefits that can improve their health outcomes, because let's be honest, our system is hard to navigate, right? So when the service launches, we are really being thoughtful about how do we build all the dashboards and analytics tools to really slice and dice by all of the demographic factors that we know are associated with disparities in our state, so that everyone who's taking care of these members can see, like, here we have an issue, how are we gonna go and solve it? And then one of the pieces I'm most excited about in the Pop Health service is our risk stratification and segmentation and tiering algorithm. So going back to transparency, we know a lot of the algorithms that have been found to have biases, many of them are proprietary. They're a black box, so even plans and others that are using those algorithms don't always know what's going in there and what's coming out, right? And how that data is being manipulated. And so, we as a state decided, which I'm really proud of us, and maybe we're ahead of New York in this regard.
I think we are.
I'm a fellow competitive spirit. That we don't have time to wait for all of these proprietary algorithms to get their act together and get rid of bias. And so we as a state are actually designing our own risk stratification, segmentation, and tiering algorithm, leveraging some of the smartest academics and programmers and computer scientists that our state has to offer, and other national experts, and are committed to making it transparent, right? Because when we get this algorithm stood up and running, it's not going to be perfect, but if it is open source and transparent, people can see what's happening, and we can iterate and improve it over time. And we know that one of the major causes of disparities in algorithms is that, data, what goes in is what comes out. And so for a lot of these data inputs, if there are certain populations that aren't using the healthcare system, or, clinical services were never provided to them, or when you even think about medical practice and who we've tested most of our drugs on, or tested most of these interventions on, that is not reflective of our population today. And so there are mathematical and sort of advanced ways of addressing that and solving for that, but it takes intentionality, and that is definitely what we are trying to bring to this project. And then the last piece, and then I'll pass it to Manisha and get off my soapbox, is really the member-centeredness. And so, another sort of core tenet and principle is the more we can democratize the data and give people ownership of their data, that is the only way we're going to get out of, again, these judgment calls about labeling people or introducing biases around the system. And so the member portal part of our population health management service is really critical, and it's going to be designed to be a tool where Medi-Cal members can log in and really own their data, provide consent, decide where they don't want to provide consent, update their contact information, update their demographic information, including language, race, ethnicity, and gender identity and sexual orientation. And I think that is another area, we'll get to sort of where along the chain are the biases introduced, and the reality is, everywhere. In my clinical practice, we had an entire initiative that was really designed to improve the collection of race and ethnicity data, which, well-intentioned, but then what started happening is, like, every patient would come and that box would be filled out. And sometimes that box and what it said there was not actually the patient's race and ethnicity data. And it was some, well-intentioned person who just looked at them, made an assumption, filled out the box, sent the patient in the back to see me, right? And at the end of the day, until we can really empower Medi-Cal members to own, it is their identity, their information, to be able to make changes and make those edits, we're not gonna get out of that cycle. And then we're also on the accountability front, really tying more and more of our quality and health equity initiatives that we can get into improving both data collection, but then also sort of addressing these disparities. So also we'll call out, we launched a new SNF incentive and accountability and sanctions program for calendar year 2023. And one of the measures in there is around complete race and ethnicity data collection from all of our skilled nursing facilities, because we know it's missing, and it makes it hard to sometimes look at the quality of care and equity of care within nursing homes. And so nursing facilities will both get rewarded if they have really, really high rates of collection, and then also get penalized where they are lagging, starting with 2023.
That's awesome, and we'll come back to it. But you can see when we had our prep call and we learned all of this work that's being done really behind the scenes, how awesome is it to be shared with all of you, and we can do follow-up as well. Manisha.
Yeah, so hi, everybody. Thank you all for joining after lunch, because I know it's a little postprandial. And I also want to take a moment to do a land acknowledgement, if we could, to acknowledge all the ancestors and stewards of this land that we get to have this meeting on and have the honor to, and all of their descendants. So I just want to lay that out there. So, what do I do? So I am a constellation of identities. I really, truly can tell you I do a lot of different things, as these ladies know. I'm involved in a lot of different things. But my day job is I'm the Senior Medical Director at Promise Health Plan. And a lot of the time that I do, whatever I'm doing, whether I'm teaching, seeing patients, doing political work, or doing work in my day job, I really talk a lot about using the moment of really thinking about how do we stop saying what's the matter with people and start looking at what matters to people and what happened to people. So no matter where I'm at, I'm always bringing that forward. So we talk about authenticity and intentionality. I bring that to any piece of work that I do. They call me the Olivia Pope of medicine. I'm #handle. And so, you know, a lot of it is really about really being thoughtful about what that is. So if I am teaching, you know, I let our residents and our medical students always know that we are taught to and trained to actually blame and shame people. And that's at a 5-foot level, right? So that's how the structural racism and how we think about health and medicine is set up to blame and shame. You're the problem. You're the reason. You need to change your life, right? That's at a 5-foot level. Now take it to a 30,000-foot view where you're in a planned space, right? I don't like to call Medi-Cal or Medicaid. My expertise is in Medicaid. I've done Medicaid in 5 different states. I don't like to look at Medicaid as being an insurance, because it's not. For many, it's a lifeline. And when it's a lifeline, it's an assurance to something. And so to me, that's really important. So we tend, on a systems level, do the same thing. We take that blame and shame concept and we do that with claims data, and we do that with cost of care, right? And what that does is it once again points the finger of what's the matter with them versus what matters to them, what happened to them. So when we think about racism in data, and when we think about all the things that we need to do, it's exactly what Rhonda said and what Paula said, is that, look, the design of the system of our country and health and medicine was built in structural racism. It's set up by design. So if we are going to dismantle those pieces, we have to ask really, really hard questions. And so I spend my day, much to people's chagrin sometimes, of asking hard questions. What's in front of us and how is it harming someone? Right? People don't want to answer that question. Part of it is because we have to answer to this person, right? In the plan space, right? Where we're like, oh, DHCS is going to come after us. But we really, what DHCS wants to know, how are we addressing these things, right? How are you moving towards a target of dismantling the pieces and structural racism that exists in the system by design, and then really being able to tell the story of what matters to people that we're serving, what happened to them, and versus what's the matter with them. And so I spend my day sort of in different spaces and places, trying to culture shift in that way. Whether it's in the day work of, utilization management, appeals and grievances, everything becomes a teaching moment, and getting people to understand that narrative is really key. So one of the things that I feel very proud of in my day job is getting people to stop saying words like high utilizers, stop saying words like those people, right? It's really simple things, right? And that narrative strategy is really critical to operationalizing equity and health equity, which is not the same as DEI, which I think we have to also address. And then really being able to be thoughtful about what that is, and really operationalizing it means to actually, the first step is really creating a narrative strategy that dismantles biases that we're seeing in our system.
Can you give us a couple more examples of the words that you're using and/or, just examples of the algorithms going haywire?
Oh, yeah. So, I mean, I hear words like non-compliance, right? People are not regulations. People are people. So you have to ask the question, right? When I hear nurses or administrative folks saying the words non-compliant, I stop them and I gently will say, they're non-adherent. So now you have to ask the next question, why? Right? Why aren't they going to their primary care person? Why aren't they taking their medications? Why aren't they engaging in the system? So when you stop saying that they're something and you start to say that there's a story behind that piece, that is just one small way in the systems on the 30,000-foot view is getting the narrative to shift towards people-centeredness. On a 5-foot view, I still see patients. I do it for free. I take care of really, really sick people. I'm a hood doc. I'm a street doc. I take care of folks on the street, and then I also take care of folks who are without papers. And I do it for free because it keeps me humble, but it also tells me what's wrong with the system, right? And when I do that work, I also stop the folks around us. It's very easy for us to get jaded. It's hard work. It's not easy. But we need to understand that racism, truly, what matters to people and what happened to people, sometimes people don't have a narrative to be able to say and do. So I will ask, do you feel like you've been harmed by racism? And you'll be surprised by what people say. And when you hear the story, right, it's really critical those are small things that we can do to really culture shift and make a shift towards dismantling a 400+ year designed system to oppress and suppress people. And so that's kind of some of the small
Well, yeah,
things.
you're right. Just
Yeah,
like
can I-
one of the,
go, yeah.
oh no, I was just gonna say, one other thing is like, language, yes, definitely is important. And, sometimes I cringe when I hear the words hard to reach, right?
Oh,
And I'm like,
yeah.
well, okay, so I know where to go if I want to reach the Black community. I know where I need to go, especially I live in LA. If I want to reach the homeless population, any population that I want to connect with or support and help, I know where to go. So I don't know. I mean, it's like placing blame, right?
Yeah.
So I don't know. They're not hard to reach. You just have to go there and be willing to go there and do the work and not have some sort of fear around interacting with a community that may not be one that mirrors your life and who you are.
And I think just to piggyback, sorry, I know you have questions to ask us, but we'll get back to them. So just to piggyback off of that, like how we translate what both of you are saying to the sort of state policy accountability level is we hear that all the time, right? Like, DHCS, we can't get this immunization rate up, or we can't get this well child visit rate up because they're hard to reach, or they're non-compliant, or they didn't show up. And I mean, you all know who you are in this room who asked me to include measures on, attempts at outreach and getting credit for trying, which, I will applaud people for trying. But at the end of the day, I think this is the flip side of where data can be so empowering and illuminating, because when we stratify the data, we see who are those communities and populations that we are, it's not that they're not showing up, we are not serving them.
Right.
And they are being underserved and not receiving sort of all of the things that they are entitled to receive. And we have to shift the ownership of that problem from the patients and the Medi-Cal members to the system that is failing to serve them. And so I think the more, data can also be a roadway or, pathway to getting to that eventual conclusion as well.
And Rhonda, you mentioned the CHCF initiative that's kicking off.
Tomorrow night.
Tomorrow night.
Yeah.
And just give a little bit more of that work, because when you are talking about going out and helping with education, it seems like there's a lot of opportunity to also educate about CalAIM, because we know we need to do that too. And and WIC and these other benefits that aren't being enrolled in at the levels that we know they should be. Is that part of it too, or how do we keep each other accountable there?
Yeah, so one of the things that we're doing, so we started a health equity advocacy training program last year, and we're starting up cohort 2 this year, and we've added a few more components, and one of the things or sessions that we've added is around the healthcare landscape here in California and health equity and translating policy into practice. So we're fortunate enough to have Catherine Haynes from the California Healthcare Foundation talk about the healthcare landscape and health equity here in California. We are also fortunate to have Dr. Jerry Abraham talk about the implementation of CalAIM and how we are translating that policy into practice. And so our cohort members will be able to go back to their community and talk about CalAIM. I think a lot of times in California, I think more so compared to most other states that I've lived in, it's the best place to be when it comes to having access to health care and progress around that. But I think one of the things that falls short is for all the great legislation that we've benefited from or we have, it hasn't necessarily been implemented to the best degree, right? So I think there's some gaps there, and we try to play a role in that in helping our community really understand 4 basic things. What is this? How does it benefit me? Why should I care? And how do I access it? So we created this communication called the Policy Rundown to do just that. How do we break it down into simple, digestible, consumable, layman's language so that people really understand what is the Omnibus Act all about?
Right.
Or what is CalAIM? Or, what it is, we want to make sure that they understand it and they know how to access that benefit for themselves and their family, so.
And can I just add to that? And I
Please.
think it's really critical what Rhonda is doing, because the thing about digestible information, we have to acknowledge the word insurance in the United States is a very touchy word. It is not a trustworthy system, right? So we have to think about what does that actually mean to vulnerable, disenfranchised folks. Folks have been harmed by the system. And just the word insurance in itself becomes corporatized just in its word itself. So this is why when we're in Medicaid, right, the system, if you look at the history of how Medicaid was set up in this country, it's a very fascinating history if you haven't. It's only 60 years old. Right, and it's young. And so the thing is to call it insurance versus, people are like, I am just trying to feed my kid. Well, hey, guess what? There's this thing called WIC. Have you heard of it, right? Oh, the government program. Well, it's true. It's part of the government. But here's the thing. It's here to help you feed your kid. Right? There's ways to have narrative and strategy and being trustworthy, right? We make the assumption that we're trustworthy. As a street doc, I can tell you, a lot of people are like, well, why aren't they just, you're a doctor, they're gonna run. They were harmed by me. Not me, but what I symbolize, right? So being able to build trust takes time. You have to engage, just like we all want to do that. You got to engage first before you're going to go shove something down their throat and say what's good for them. And so I think that piece, it's just language that is relatable, reliable. Do you look like me? Are you somebody that I know that I could trust to serve me?
Yeah.
That's a whole other piece to it. And I think the language that we use in the system of health is so academic and sterile that we've forgotten the people piece that goes attached to
Right,
it.
or even the trust around, what are you going to do with my data and information
Right,
that I
what are
give
you
to you,
gonna
right?
do?
And then, there's rightly so, mistrust that goes back, multiple years when it comes to what the community has done to Black and brown
Exactly.
individuals. And so when you think about that, like it's supposed to be here to help us, but there's a historical, background that has brought harm to us. If you've read the Henrietta Lacks story or medical apartheid, all of those things are documented and very true. And so part of what we try to do too is, especially when it comes to helping our community understand the importance of participating in clinical trials, right? As a means to close the gap in health disparities and making sure that the drugs that they're taking are as efficacious as they can be for multitudes of people. And so we have to deal with breaking down that mistrust and owning that, right? But also helping them understand that there are protections in place for them as a patient that, prevent those kinds of things from happening anymore. But it's not easy, especially considering which generation you're working with.
Yeah, and if you build data infrastructure without a historical context, right? If you build data infrastructure without understanding how we got here, right? And then you want to go analyze that data, you're going to create the flaw. It's sort of what Pallav was saying, what goes in and what comes out, it's flawed from the get-go. And so it's just really critical that we need to lean into the uncomfortableness of being able to have that conversation in spaces that really have good intention. Even on a plan side, been in many plans and doing Medicaid, and that's the first thing we think about. How did we get here? What is what are we missing? And knowing that missing data, it's Waymark just came out with this really brilliant, Sanjay Basu came out with this brilliant paper in Nature. If you haven't read it, you should. Sadiq Patel, I think, is the first author. And they talk about the importance of missingness. Meaning that just because the data that's in front of you, it's kind of like documentation. When we review documentation in health system plans, it'll say, the complaint will be, well, my doctor was racist. My doctor was rude to me and was racist. And then I will get from the nurses, they'll say things like, well, it's not in the documentation. Just because it's not there doesn't mean it didn't happen, right? And that missingness, the things that are missing are just as valuable as the things that you're seeing. And so understanding historical context, then you need to ask the question, because I understand the historical context, what's missing in this data? And then how do we build from there?
And I think I would just piggyback onto that to say the only way to dismantle that is in collaboration with the communities that have been left out, right? Like if we just keep trying to do the same things we've always done, we will fail because we're just making those same historical mistakes. And so, for example, when we get to the member portal piece of our population health management service, like there is going to be deep engagement with Medi-Cal members because we need to be able to get to that point to say, like, is the way this consent set up, does it make sense? Does it explain the why and the how of the data sharing and how this helps you? And it's not just your data is going off into some black box to be sold or, monetized in some way, as happens so often in society today. But without engaging those communities, which is hard and time consuming, we're never gonna get to a better place.
Actually, it's a good segue to what's happening at the federal level with ONC, the Office of the National Coordinator, and I believe that Mickey Tripathi, who is our coordinator, is the chair of an AI initiative with this idea of having a nutritional label that is part of the AI algorithms that we all can understand and be aware of. I don't know, Pallav, if you've been connecting there, you want to say any?
I don't know if anyone from CDII is in the audience. If you are, raise your hand, because you're probably better poised to answer this question. But, obviously, I think ONC has been working very closely with the Health and Human Services Agency in the data exchange framework, so that even as California, charges ahead in a number of these domains, we're staying sort of aligned with where the federal government is also headed. So absolutely, AI is here. It is going to be here, whether anyone likes it or not. And I think thinking through how do we not make the same mistakes that we've made before is really critical.
And I think that's another question for each of you is, are there any legislative or regulatory gaps that you see in the near future that we should be thinking about? I know, Rhonda, from the New York experience, it's started there.
Yeah, tough. I mean, yes, so with the advent of AI in medicine, we have even more concerns about how that may impact or the influence of racial bias in that. So we're exploring what we could potentially do on the policy and legislative front. We haven't figured it out yet, but that's our mission. So I'll let you know when we do, unfortunately.
Yeah, and I think for everyone in the audience, I think it's going to be sooner than we think. There was a piece of legislation around AI last year. I expect that to grow tremendously for us to be really kind of putting all of our heads together there. Any other gaps of policy or?
Yeah, I was just going to say, it needs to be across the board from, even when it comes to medical devices, right? And
And
clinical trials, it has to be definitely a broader scope.
And transplants, right?
Yeah,
Transplants is another
transplantation
big
too,
one, right?
yeah.
Exactly. So,
Pallav, do you have anything there?
No, I would just say
Regulatory from the regulatory front.
I think Rhonda was speaking earlier about, we in the state have moved so far in so many areas of regulations and legislation, and I think we can all acknowledge that sort of how it is implemented and reaching individual humans on the front line is still an area we really have to work on. So I would flip the question and be like, not that there isn't stuff that needs to be done, but I think even if we buckle down and focus on that implementation gap today, there is so much progress that we can make.
So much opportunity on the accountability for members and patients to be at the center as well, and we haven't quite really been able to figure that out. So we're going to go to questions. So think of your questions. We already have one in the room here. Before we go to the questions, I just want to just do a quick lightning round with each of you to think about what does unbiasedness in data sharing and data look like? How will we be able to feel it, touch it, know it, that we've succeeded? Quick answer. Putting you on the
You want
spot.
to start?
Oh my God.
Go, Manisha.
Oh, what does it look like? Well, I mean, to be very frank, I'm going to take it to the people level, right? What it looks like is that everyone is thriving. Like, Medicaid should not be an afterthought, right? It should be front and center. And so if our most vulnerable thrives, that means everybody's thriving. And that means the data's telling us a story. So to me, that would be what I would dream for. And that's what my sort of the legacy footmark that I want to be for my career is always going to be in that space, to know that every single one of us is thriving.
Love that.
I'm just going to go back to the guiding principles. I think without transparency, we will never get there. And then really thinking about the democratization so that the story the data is telling and what the data is not controlled by a small, relatively homogenous group of people.
Yeah, I mean, I think, it's not, health equity is not one-dimensional. It's a very complex situation. And I think, at least for me, one of the things that I would love to do is, when we think about getting to the root cause of inequities, is what can we do, and going back up to even the medical school curriculum? Because by the time a provider gets into a clinical setting, it's way too late. And so if there's something that we can do, I've been exploring this idea, to address what can be done to make sure there is health equity education and not just one course that's taken or one class, but an entire curriculum around health equity and really addressing the issues as part of the medical school curriculum. I would love to see that happen and figure out how we can do that.
Totally.
And workforce development.
And work.
Just add that for you.
Yes.
Okay, so let's go to some questions in the audience. Yes, and we have a roaming mic here.
Thank you. Can you hear me?
Yes.
So yeah, my name is Michelle Lavander. I'm with the USC Center for Health Journalism. And it's been a fascinating conversation, and some of the things I'm hearing about accountability for patients and members, transparency, and giving people control over data. So I wanted to ask about something very specific, which is Medicaid has expanded exponentially, starting with Obamacare. And basically, those Medicaid population is some of the most diverse parts of our healthcare space. And there's a lot of data that we could get, like nursing home compare, hospital compare, commercial plan data, but all the data on individual Medicaid providers, FQHCs, and what are called providers, but are really consortiums of clinics like a Ultimate or something like that, are all lumped together by health plan and sent to the state. But any broken down information that could allow a consumer to make an educated decision about where they want to go for their health care is utterly out of reach. And I'm part of a coalition that included folks at USC from the law school, the journalism school where I live, and a healthcare economist and National Health Law Center, multi-year effort to get this data from LA Care that culminated in a lawsuit that we just lost. And I'm just wondering, is there any effort, speaking of regulatory or legislative fixes, so that people can have the information they need to know who's doing a good job and who isn't?
I'm happy to start. and then
Yes,
you guys can
go.
layer on. I think it's a great point and a great question. And so, I think as everyone is probably aware, in California, as of this January, 99% of all of our members are in managed care plans like LA Care, whom you referenced. And so, first and foremost, I think we are starting with the transparency level at the managed care plan level. And we have been publishing more and more data about quality outcomes by managed care plan, which wasn't always easily accessible unless you were reading our 3,000-page EQRO technical reports. If you did, bless you.
Nonsense
It's
right
good
there.
bedtime reading. So, starting with that layer of how can Medi-Cal members make informed choices about which health plan is right for them, but definitely acknowledge the gap and the need to go further layers deeper on the provider side. So we can definitely take that back.
There's no one making a decision on a health plan level as a consumer or family. It has to go, I mean, for an individual or community, that's a meaningless level of data.
I would love to talk to you afterwards too with the coalition that we run. So there's something there we can pull through. I saw Greg.
And then
We have Claudia and then Greg.
Hi. This probably is a question for Pallav, but others can love your comments. In a world where most Medi-Cal members are in plans, and thinking about the upcoming hearing in DC, where Senate Finance Committee's asking how should we be thinking about AI tools for Medicare, a lot of the questions revolve around things like avoiding. It's not just a sort of clinical care side. It's also avoiding claims denial, avoiding prior auth decisions that are incorrect, which might require a proactive set of policies or oversight between the payer, in this case Medi-Cal, and the plans around their use of the tools. Often these are third-party tools, so the plan may not even have transparent insight into the way they operate. So I would just love to have some thoughts about any conversations that are happening about that. What are the options for that kind of oversight? How do you build the capacity and skills of the state also to do that kind of work?
I think it's a great question and a hot topic, obviously, across the nation. No clear sort of immediate answers, but I will say I think collectively one of the areas we've made a lot of progress on in California is collaboration and coordination among different state departments. So, my DMHC colleagues are here. We connect very closely with HCI, with Covered California, with CalPERS, with CDII. And so, I've only been at the department 3 years, but from what I hear is sort of our cross department collaboration is stronger than it has ever been, which is laying the foundation for some of that. Because what we don't want is a piecemeal approach, right? Totally committed to Medi-Cal, but there are other consumers who also need the same protections across the state who have other forms of coverage and insurance. And so some of that partnership is really laying the groundwork for, as some of those decisions at the federal level get implemented, how can we have a coordinated response that spans payers, spans multiple departments, and we're not doing this piecemeal, because otherwise we will not really address the problems that you are raising.
Music to our ears. Greg, do you have a question?
and then
Right.
and then the lady in the pink.
Okay.
over there.
Hi, Greg Buchert. And Rhonda, you mentioned briefly about clinical trials. And up to this point, most clinical trials have been done on people that look like me. And so how do we, so we've got very selective data on how well drugs work on individuals. With the history of Tuskegee study, regrettable studies done on prisoners, persons with disabilities, and others, what are going to be effective ways going forward to recruit a broad base of individuals into clinical trials?
Great question. And so what I can say is I know that, it takes a village sometimes to make all that happen. And I think there was a lot of success during COVID in increasing diversity in clinical trials for COVID vaccines, especially with Pfizer, Moderna. But I know that there was a coalition of Black doctors who were well-trusted, who did webinars, who went out to the community to talk to folks about the importance of being part of this research or this clinical trial. So I think it's going to meet people where they are and helping them to understand the importance of that and breaking down those, I would say, individual barriers and the mindset around medical research and participating in clinical trials and what that really means. So Yeah.
Yeah, no, I was going to add, so what Rhonda's speaking about during COVID, so we really, so I actually co-founded a sort of a social impact group, if you will, where we actually highlighted Black doctors to basically, we were able to get them into the media, into the masses very quickly and train them to actually being able to be the trusted, relatable, reliable folks. Because, and that's actually, if you see all the Black and brown doctors, I mean, this is just me, this is not my day job, but this is just like on the side, is that all the Black and brown doctors that you see on TV actually are part of our group. And the reason was because during COVID, Black and brown people were dying at astronomical rates, and nobody on TV was looking just like them to actually trust what is this new thing that's coming out to vaccinate the masses, right? And so we did that, and that we actually did see a bump. I would say that we have a long way to go, and again, and it's because what happened at Hopkins, and what happened at Tuskegee, and what happened in all these, again, historical context matters. That wasn't long ago. So we have to understand that the elders that are in generations of families that have been harmed by the system are still living. So we've done a lot of work around making sure that people are relatable, reliable, and they're experts. That's the other piece of this, is that people do want to hear from their doctor. They want to know their nurse. Like, they want to know that you know, but I need you to look like me. And so to answer you, so that's what Rhonda's speaking about, is like that we did a lot of work around that during 2020 now, and still. So we have about 250 doctors.
Right,
in our
and we
cadre.
actually, with a lot of persistence, we were able to get Dr. Kizzmekia Corbett
Yeah.
do a webinar with us because I felt it was important for us to do our part to educate the community, to try to dispel a lot of misinformation and myths that were flying around the community that people bought into, that influenced them not to get the vaccine. And so we were able to also provide the opportunity for them to interact with her and ask questions directly of her about the vaccine and things that they had heard. And it was great to get emails after that says, I wasn't going to get vaccinated, but now I know and I'm going to do it. So it really made a difference to hear it from someone who's a trusted source, who looks like them. And in this case, she was actually the one to develop the vaccine. So, and we've also had members of the Henrietta Lacks family participate in some of our events to talk about, share their grandmother's story, yes, but also talk about the role the family plays now in the decision-making for the HeLa cells and the importance of our community participating in clinical trials. So here we have, the family of a woman who was totally, misused by the healthcare system, but now they're, advocates for participating in clinical trials and educating the community about that. And, front and center and what happens now with the research. And there was just a settlement from Thermo Fisher a few months back last year. Yeah. So.
And I think what both of you underscore is how critical, this is what ties back to the DEI, that until we can get a workforce at all levels of the healthcare delivery system that reflects the population we are serving, we are going to face an uphill battle, really rebuilding that trust and making progress, both on the data inputs, but also how we address, okay, we've identified this disparity. How are we going to solve it? How are we going to build trust with the community and really close those gaps?
Well, one thing I just recently learned, this is the UC system, there's a partnership with HBCUs.
Yes.
I just recently learned.
Yeah.
But it's not highly publicized.
No, it's
right,
not,
it's
no.
right. But it's a great program.
Well, and then I'm going to use DHCS for a second. DHCS is giving money for really thinking about health equity transformation. And one of the things that I brought up at a meeting, still going to say it here, I'm going to say it in front of you, is that, part of that money. So one of the things that I hear from residency programs is, we can't find Black doctors. We can't find Latine doctors. California, hello. And so it's like, okay, why can't you find? We just can't find it. So part of health transformation and the health equity money that is in DHCS, I think would be really innovative if you're in a plan space, that part of that money that they have to use is to develop the workforce and incentivize them to go and find the doctors in training, because they're there. Every time, it's sort of what Rhonda was saying, is like they're hard to reach. Well, no, they're actually not. You're just not looking in the right place.
Yeah.
And so I think there's so many ways to think about, what does this look like? It is imperative that we actually look at this, right? This is not a nice to have, this is an urgency factor. Deloitte and if you don't believe in it, I'm not saying anybody in this room doesn't believe in it, but I'm just saying, if you are a numbers person and it's all about finances, Deloitte did a great business case that actually stated that if we don't look at this inequities in healthcare, right? It costs us $320 billion today. It will cost us $1 trillion by 2040 if we do not address it. So there's a financial imperative on top of a moral imperative. And so I think that to me is critical to actually think about as we move forward, because folks are going to be more, it's a blended society, and we need to be really thoughtful about how we shift the narrative.
And if you were there last night, a spiritual commitment as well. I know
Yes,
it's a really
absolutely.
amazing takeaway from Bob Ross. So one more question here, and then we'll wrap.
Okay, thanks so much. Thank you all. This has been really illuminating and invigorating discussion. My question is on a little bit more granular level. So we're a community-based organization that's an enhanced care management and community supports provider. And, we actually have quite a bit of success with reaching like grossly underserved, like historically disenfranchised folks. But we encounter the same barriers to accessing key players in the healthcare system, and we don't have access to their records. And there's no incentive for the clinics, as we had the good fortune of being part of both health homes and whole person care. And one of the things that was really lost with whole person care is we no longer had the shared portal, which I know is sort of coming. I don't know exactly what it's going to look like, but we're battling for access to get anyone to return our calls. We're supposed to be coordinating transition of care follow-up, but we can't see hospital records, we can't see clinic records. And so in a sense, that type of data sharing, for community-based organizations is also so fundamental to our ability to even do the role. And so I'm begging and just trying to make connections with people. And so if there was some way, do you have advice for how to make that happen, or a vision for that improving?
I'm just gonna say I 100% feel your pain, and yes, in clinics, still sometimes try to get faxed records sent over to me so I can figure out what happened to my patient. So I totally understand. And I think this is really underscores the critical importance of our data exchange framework at the state, right? And I recognize for many people, it's conceptual, et cetera, but getting that in place and implemented in an actionable way on the ground is what will help solve that problem. And then obviously, once we get the PHM service, it will improve and grease the wheels on some of that accessibility. But I think it's really why we all need to lean into the data exchange framework and break down the silos that exist within the healthcare environment. We're not even talking about sort of justice or social services data. It is that you are a contracted medical provider of ECM and community supports and need access to that data in real time. And then happy to talk offline about the specific county and situations and see if we can help.
And I would be remiss for many of you who know the work that we do with Connecting for Better Health. That is exactly why we started the coalition 3 years ago, was to be able to ensure better data sharing in the state. Happy to connect with you, and I echo that the data exchange framework is an asset for us. And I was talking about it over lunch. Many times with compliance officers, you'll get the no. With the data exchange framework, we can get to yes very quickly. And then we work on how do we implement it. So I would, for all of you in the room that haven't looked up the data exchange framework, it is an incredible piece of policies and procedures that the state has led, and many of us have contributed to, and there's a governance ability for us to continue to contribute to it. So happy to follow up. But I don't want to end on me. I want to end up with one call to action with each of you for all of us in the room. And I see so many of you, new faces that are out there doing this work day to day. So what would be your call to action? What are we going to do differently when we walk out the door? Rhonda's like, who wants to go?
Who wants to go first?
Manisha, you always get us picked on.
Yeah, you're pretty good at that.
Oh, you're funny. I love it. Thank you. Vote.
Yeah, you're right. That was exactly. So she's really good. She read my mind. See, even what we wore today. I know. Right?
It's all good.
Yeah. I echo. That's exactly what was rolling around my head. There's an election coming up. It really matters. You know, I say to people, like, okay, so we have policies, right? Who creates policies? People. And those policies dictate what investment or disinvestment goes into certain communities, or what, you know, policies happen that benefit certain populations of people versus others. But we have the power to choose the person who can best represent our interests and benefit our community. So yes, definitely our voice does matter, and that's a lot of what we do too. I think a lot of times people in our community think their voice doesn't matter, their voice has been marginalized, minimalized, and so we try to give them you know, back power to their voice and participate in the process. If you don't participate, then, you know, you have no one to blame but yourself. But we do have the power to drive change. And I grew up in the 60s, not to date myself, but I constantly talk about we need to get back to being activists, right? And we're trying to really ignite a Black health movement here in California and engage our community around being advocates as well as activists to drive change and really participate in that process. So I would go out and tell everybody about us.
Yeah.
And like, you know.
But I also think you should know the law, right? So the National Voter Registration Act, if you are a Medi-Cal enroller in this room, or you're touching any enrollment in Medi-Cal, you are actually obligated by law to register people to vote.
Yeah.
The IRS also states that if you are a nonprofit organization, you have an obligation to register people to vote. People who receive Medi-Cal as their health insurance are the most underrepresented in civic engagement. And just so we're all clear, Healthy People 2030 states civic engagement is a social driver of health. So I just stress to you that if you're an FQHC, you are taking Medicaid or Medicare dollars, you have an obligation by law, by the National Voter Registration Act, to register people to vote. So not just you voting, but go get other people to vote.
Paula, do you want to?
No, I'm going to leave the last word to both of these ladies.
All right, can you give them a hand, please? Thank you.
Thank you.